Our last speaker for the session is Dr. Jane Ho, who is from the Trapeze service in Sydney and transitioning adolescents. Dr. Ho, over to you.
Hello. All right. Well, thank you very much for inviting me to speak today. Please call me Jane. I work at Trapeze. It's the transition support service down in Sydney, across both of the children's hospitals there, at Children's Hospital Westmead and Sydney Children's Hospital Randwick. And I'd just like to start by acknowledging that we're meeting on the lands of the First Peoples, and in this area it's the Turrbal and Yagara people. And I pay respect to Aboriginal people who are here today, elders past and present and emerging. And it's my sincere wish that we all share and act on the vision that is the Makarrata. Maybe it's turned off. Anyway, I wanted to start by saying that it's a great privilege to follow on today. Thank you. In speaking about transition as part of adolescent health, and following on from Jenny's beautiful keynote speech this morning. And as she alluded to, adolescent health is still quite an emerging area of medicine that we're dealing with, and it's a real privilege to be working with this age group. The area that I mainly deal with, and that area of transition, and that idea of leaving children's hospitals, preparing them in a good way to have perhaps a graceful exit, and also to move with optimism onto the next step, is actually in some ways an artificial construct. To do with age, we have, as Jenny said, there have been changing ideas of what constitutes child and what constitutes adults. And where I come from in Sydney, actually that it's dependent very much on the age policy of 18th birthday, and that's the end of what age the children's hospitals down in Sydney will look after until, and to move on from that. But in fact, around the world, that age is variable. Sometimes it's 12, and other places it's up to 25. And then there are also new models, such as the one that Henry is going to start up on the Gold Coast, up to 25, isn't it? 20 to start with. So this idea of transition is, and then world domination after that. So this idea of transition is actually it's a flexible concept, but I hope that from this you keep in mind, actually, it comes back to the young person, and that, what can we all do as part of our jobs as clinicians to support their individuation, their emerging independence. And sort of just like this very nice picture, life could be a pathway, and maybe they take one path, but it's okay if that path doesn't work out, perhaps they take another path. And in the same way with their healthcare transition, there may not, sometimes there's a really clear transfer of care to the adult side, but sometimes there isn't. Also, I wanted to sort of build on this idea of why adolescents are important, and why I really love to work in this area, because this age is completely full of promise. And to think back to 2014, when the World Health Organization called it a second chance in the second decade. And so I find that very refreshing. And also that idea from the Lancet Commission in 2016 on adolescent health, where they said that whatever we put into adolescence, it yields a triple dividend. And very much so for us in transition. We get that dividend perhaps in immediate improvements to their short-term health. There will be you hope that there will be long-term improvements in the way they look after themselves in the decades to come, but also there'll be dividends into the next generation, because these young people, of course, go on to have their own children. So just two pictures of the two hospitals I work at. We're a network, and everybody gets along most of the time. So now, when it comes to transition, I like to, this talk, it's a little bit about how do you set up a transition service, but also I wanted to talk to all of you, and perhaps you're already doing it, but how I just wanted to give you an idea of how I approach transition and the few things that I am interested in and I like to cover. So when I see young people at Trapeze and we get a referral, so Trapeze is part of these two hospitals and we're a standalone transition support service. So we were created almost 10 years ago, and our work is, standing on the shoulders of other giants. So we didn't start with transition. There were other people who were already working in adolescent health and planting that seed throughout the rest of the hospital. In fact, there was another program statewide, funded by, outside the Children's Hospital, called Agency for Clinical Innovation Transition Care Network. So, like, for all of you, when you think about transition, when you work with young people, think about, are you coming from, what's the context of your work setting and your environment, and are you already building on something that already has a strong foundation, or whether you're part of setting up that foundation for adolescent health. So our team at Trapeze, we're about 8 people. It's all very multidisciplinary. So there's me, so coming from that paediatric adolescent doctor background. Then we have nursing staff, we have occupational therapists, we have social workers. And in fact, everybody does very similar work, which is transition coordination. And it is, in concept, very easy to do. It's very much being organised, knowing how the healthcare system works, being good with administrative stuff, follow-up, that logistical type of thing. But if you wanted to do it really well, then I'd say that it's really important to have, to be comfortable with chronic conditions, to be comfortable with that adolescent frame of healthcare. And that is looking at the whole person, something that I think, today, this afternoon's talks have all been about today. So it's a, biopsychosocial. And so when I see somebody and start that transition conversation with them, there are 3 main areas that I look at. The first one is, these young people, we're looking at them in their developmental context. So we really want to think about, independence and self-management. So that idea of individuation, they're growing up. What is their capacity? And for most young people who are able, cognitively able, there's a lot to talk about from that point of view. So in terms of independence, do they have their own Medicare card? How much are they taking on if they're taking medications? Are they responsible for taking them? But I don't mean just about those things. There are other administrative tasks that are super important in terms of looking after your health. Do they make their own appointments? Do they know, when their scripts are running out and know how to get to the chemist to fill them again? So these really super boring administrative tasks that are really important in looking after one's healthcare. So that's the first area. And we're lucky at my hospital because, in fact, we have a specific self-management clinic in our Department of Adolescent Medicine. But in terms of whether or not you have these resources or not, you can all talk to young people and foster this development and growth, even from when they start high school, from 12, even earlier. Spend time with them, invite them to speak to you without their parents present for 5 minutes or something, and develop their ability to speak for themselves and to answer questions for themselves without their parents understandably trying to do everything for them. It's also about changing that balance of how much parents do for their young person and how much they do for themselves. And it's never about a message saying, actually one day, no parents, adults not allowed to sleep by the bed, they're not involved at all. And that's not even a true thing. Probably for all of us, we all recognise that there are times when we all need more support. So it's more a concept that is elastic and responsive to whatever is the intercurrent stressor. The second area I like to look at is just transfer to adult healthcare. So what are the chronic conditions that young person has? What are the medications they're on? Are they getting them all through the local pharmacy, or are there more complicated ones that only can be dispensed through the hospital pharmacy? who are the health teams involved in these young people's cares? And are they based all in the children's hospital? Is there stuff going on in the community, like with their GP? GPs are super important because with our health system, we've got these structural differences where we've got lots of general paediatricians, but in fact very few general adult physicians. So GPs at all points of life hold and should hold a very central role for the care of children. And in terms of preparing them for transition, very important. Thinking about, stuff, do they have anybody in the community? Usually this is allied health, and in this respect, the NDIS has been very good for that time of transition. The third area that I like to look at is psychosocial transition. So not only are they leaving hospital and children's health services, there are lots of transitions going on in different areas. So they're leaving school, they're turning 18, so legally they're becoming an adult. This is a time when, doing having a heads conversation is very important, because increasing role of peers and that influence of peers, their mental health. There are lots of conditions that perhaps emerge during this time of adolescence, or say autoimmune disorders, that perhaps the disease control can get worse. And often it's the psychosocial components of a young person's life that has an influence on how well they look after their healthcare. So whether you work in a specific transition service as I do, or whether you work by yourself, you can all do these things about having these conversations. So in terms of if you're interested to set up more transition support for where you are, or setting up something in the hospital system, similar to where I am, there are actually lots of things that you can think about, because transition, not only is it about complex health systems, we are actually also working in a complex health system, and to set up a service is, you have to think about that whole context. So one, having resources and money to have people is very important. You've got to think about why you're doing this. What's the message that you want to communicate to all your colleagues and to the networks? What is your aim? Do you want to have a bigger vision than that? Is it you want to support transition for everybody? So it's good if you want to think through those things clearly, and to perhaps start changing the culture. Now, in our team, we of course would like to help everybody transition, but in fact we're very limited to how much we can provide. So we've decided to have a prioritization grid in terms of what we can do for everybody, and for that would be resources and education. We've got a website, and we run general transition webinars every couple of months or so, because in fact having this spiel about transition is something that is similar to most people. Okay, there's a subset of transition spiel for those with intellectual disability, because they have very specific extra needs. So that's sort of the base level of transition. We really want to reach everybody. And then for the top level of people who might be complex, they have more than 3 conditions, they have like multiple teams involved, maybe they're 17, maybe they're already 18. We get these referrals. They need extra help. So then we have a team-based approach, and then it's 2 of us working in like a standalone transition clinic. We see them, we go through this transition assessment, and then from that we've got a whole idea of what is needed. One of the most useful things what we do is something very simple called a transition plan, and all it is, it's supposed to be 1 page or 2 pages, but often it's much longer because people are complicated. And it's just got a summary of their health conditions, their medicines, and a bit about who they are. And then the second page it's a table with listing all of the teams and healthcare providers they've got on one side and on the paediatric side, and then trying to find out and to discern who would be the ones that they link to on the adult side. Now, I don't know, but all over Australia, all the healthcare systems, but in New South Wales, it's complicated, because when you're coming to the children's system, it doesn't matter where you live, it's a statewide service. As soon as you turn 18 and be part of the adult system, it's all about care close to home, and people are confined to their local health district. And so the difficulty is for a lot of the young people who are coming through needing transition support, they have really rare diseases, they have complicated stuff where clinics and care is not available within their local hospital. So often, they can go from a 1 hospital system with some community and GP support And then as an adult, they might need to be linked to 2, sometimes 3 different hospitals because they just can't get a coherent sort of provision of care anywhere else. There can also be very simple transitions as well, okay? Things that, such as people with diabetes team have been working in supporting transition for many years without adolescent doctors. One multidisciplinary team to another multidisciplinary team. They've been very responsive, and in New South Wales we've got lots of young adult diabetes clinics. So if you're thinking, coming back to setting up a transition service, it's back to communication again. And so having, our hospital is sort of newish. I think we're about 20 years old or something like that. So we've got an electronic medical record. Probably all of you have one as well. But that sort of way of knowing what are the other teams doing, what are they thinking, with their last clinic appointments, and for us to have our forms and our communication on EMR so that everybody can see what's going on, what's the transition plan, and talking to the young person and their family, but also talking to their teams about the time frame. So it's not just this abstract concept of, one day you'll leave here and you'll go to adult services. It's actually trying to nut through, well, what's the timing? What are we aiming for? And in general, for those complicated ones, we like to really encourage people to have already had their first adult appointments before they leave children's care. Other things that really help are having executive support, having that clear age policy that motivates everybody to work together, having education, so presenting at grand rounds, being proactive and speaking at different specialty departments and speaking at their regular meetings is really important. Sometimes, the different models of care, so then you've got this standalone transition model of care, you've got a specialty-based model of care. Sometimes there can be a lot of room for working together. So there can be, for example, we have like a brain injury rehab transition clinic that started last year, and our trapeze team will go and work with the brain injury team. And then, so the brain injury team do their bit in terms of treatment and care, and talking about, well, where are the adult referrals going to go? And then people from the team I work with talk about general transition and other things as well. So that idea is really helpful. I think there are also other things that you can develop that help this idea of transition for young people within your hospital setting or within your work setting, and things like graduation ceremonies, things like peer support. And in fact, we've got this very successful chronic illness peer support, and that's something that started down at the Royal Children's Hospital in Melbourne. There's, now it's been in Sydney for over 10 years. I think there's been one in Gosford as well. So it's really wonderful to see young people having a voice, speaking about other things, whatever is important to them. Okay, transition is one of those topics that comes up a lot. It's also important to have those links outside of the hospital. Okay, so to develop that knowledge of adult resources. Where are the clinics? To have an idea of the map of healthcare services. To know how does it work? Is there a transition champion in each adult hospital? Who are the pharmacists? Can the pharmacists talk to each other? So it really is very much, you can't do transition without collaboration and working with other people. It's all about getting other people to do things. All right. I think that's about everything. And also, don't forget data and evaluation. So transition is part of adolescent health, and it's an even younger part of it. And so in terms of, what is the solid data and evidence about, having transition services and that it works? I don't think that we have really solid, we're still in this sort of first phase of collecting data and evidence, and this is all over the world in terms of transition. But, I would think about things like, for the young people and their families, that how much anxiety is there, what is their experience of transition, and have we improved it for them? That has been, a really big hurdle. Think about, have they, mapping service data, how many appointments have they actually had in the adult system? If they've had 1 or 2 and showing that regular attendance, and I'd say that's a win. Are they linked in with a GP? That's also a win. And how about measures of their disease control? So not every condition is measurable as easily as diabetes and HbA1c, but sometimes, you can think about those things as well. So, I forgot to change my slides, but this is sort of just trying to show, the mess that is our health system, how complicated it is, and in transition you needed to pull out all the different strands. And back to communication, most families have this myth that their health records are automatically visible wherever they're going in the health system, and that is so not true. And so part of it is encouraging young people to start asking to be copied in clinic letters, if they're not already, for them to have copies of the relevant reports, for them to be able to have something on their phone that in an emergency they can tell people. All right. And just, that was just a nice picture. And thinking, if we can support young people in this area, and I'm sorry because I haven't talked about the psychosocial transition and how we can support them, then perhaps they can have good management of their health and go on to do all the things that they want to do and to live their life. Thanks very much.
Thank you so much, Jane. Do we have any questions from the audience? We've got Ange over there. Oh. Yeah, have a look. So trapeze.org.au. Also, our sort of sister service, ACI Transition Agency for Clinical Innovation Transition Care Network. We've developed a lot of our resources together, and you can also look on their website.
So, hi. Sorry, Jane.
Andrew.
Hi, Jane. Sorry.
Oh,
thank you for the talk. I'm going to ask you a different question from one I told you at lunchtime that I was going to ask you. And that's about communication and correspondence going out to the young person. I've started doing that while I'm in the transition phase for young people. I also do send it with the permission of the young person to their parents as well. Is there a point in time when you no longer send it to their parents? It's an interesting one and controversial in our service because they've said that to save on admin time, they're no longer going to send the letters to the families at all, which we're fighting at the moment.
Oh, that's a bit shocking. What I would say is, I'm all about openness and transparency, and so in an ideal world, I'd just check with the young person and say all of this is helpful and we're all very open about it, and I'm very non-committal about whether it goes only to the young person or to I usually try to send to both, actually, yeah. Because if you look at a lot of what's in the literature, there is so much parental anxiety about, about transition, about letting go, and that the anxiety is not addressed if you cut the parents out. In fact, you can help the anxiety by really acknowledging it and supporting the parents to take up their role in helping the young person with self-management. And so actually, I usually just mention it and say this is something that we ought to really encourage. Parents, you've been doing it for all of their life. Can you start teaching them when you make an appointment? Make sure they're with you. Sit by their side and they can do it, but then you're doing it together. And I think that's the way really to support the young people taking on that care for themselves, and at the same time having the parents be really relieved and being able to step back. Okay, and then Andrew.
Hi, thanks for that, Jane. I'm Steph. I'm an adolescent med physician from Monash in Melbourne, and we're trying to currently improve our transition services. So that was really helpful. One of the big barriers
we started after you.
Yes, keep trying to improve. Ongoing process. One of the barriers we've found is the young people who are quite complex with both physical health and mental health conditions. And I just wanted to ask, I guess, what type of relationships or processes have you formed with your mental health colleagues to help that process? Because that's something we find quite difficult.
This is super difficult.
And even when it's not complicated, when it's not intellectual disability with behavioural problems or ASD or something, even when it's something as simple as ADHD, I think the difficulty is money. And we know from the Access study that money is the big barrier for young people to access healthcare. And unfortunately, in New South Wales, we have, say, community child health centres and CAMS teams that do provide a community base for managing paediatric age with, all of the, ongoing things like ASD or therapy and all of that, or behaviour. And as soon as you get to the adult mental health model, they absolutely do not provide this. And it all has to go into the private world. And it's something, even if you have a good transition service, if people can't afford it, there's nothing to transition to. And so we come across this problem. How do we work around it? I guess we try advocacy. So we try to approach individual psychiatrists and ask them, these people, they have a healthcare card, is there any opportunity that you could consider bulk billing them? So that's our only approach at the moment. Although I think, there was the Henry report in New South Wales and looking at paediatric services, and one of those things is that actual transfer of care. So it may be that Medicare will change the system. It may be that stimulant prescribing, as an example of ADHD, those access issues will change.
Thank you. We've got time for one more question, Andrew. It's you.
Hi, Jane. My question might not be needed now because I was really going to ask similar, but I've doubled up on paediatric conferences in the last few days. So I was at the MBPSA in Sydney last week, and there was a big session on transition when there's intellectual impairment and disability. So yes, we've got physical, yes, we've got mental health is added there, and then I'm going to add intellectual disability on top of that. But your answer's probably the same. There probably aren't pathways, and it's probably just more complicated, I'm guessing. I don't know.
No, there's so much more with ID. The families can be so vulnerable, we adults don't have the services. In New South Wales, they set up these intellectual disability mental health hubs. However, they're not for ongoing treatment, they're just assessment services, and to even be eligible to be seen, you need a private psychiatrist already. So it's still an inequitable system. Like seriously, there's just a handful of adult psychiatrists I could list in Sydney who I know of.
Just learning from Ben's conversation yesterday, one other way to reframe that is to say that the thresholds for both adult physical health and adult mental health are different to our thresholds of care in child and adolescent health, and that's a systems pressure.
I mean, you can understand, because paediatric is just 0 to 18. Adult services are 18 up to the end of life. Their volume is so much bigger. So it's not their fault.
Yeah. And
yeah.
And who does the guardianship process? It seems to me it makes more sense to be done by us because we know them, and if then they can go into the adult world with that already sorted out, particularly with the disability insurance agency and any other sort of supportive agency, and kids going into psychiatrists who are felt to be capable of going in by themselves and know nothing about what's going on.
Absolutely, yes. Guardianship is a conversation we always have in our general transition webinars for those who don't have the capacity to make decisions. What I would say though is it depends on the guardianship division or the guardianship board within your state. I know that the one in New South Wales is trying to encourage the public that if there's not a formal need for guardianship, so for example, there's a family have a young adult who's clearly got severe intellectual disability, they're living at home, their parents are their primary carers, and that nobody is opposing the parents' right to make decisions on that young person's behalf, then what the guardianship tribunal says is there's no need to apply for guardianship, that informal process is fine, that the parents, there's a hierarchy of persons responsible, and the parents actually are not number one, they're like number 3 or something like that. But as long as it's clear to everybody and there's no disagreement, there's actually no need to get a formal guardianship order.
Thank you. I think it's a really important question and does involve a lot of our paediatric cohort that are graduating through into the adult model of service. But I'm just mindful that the ice creams are starting to melt. So at least I believe it's the ice creams. Thank you so much to our presenters.